Okay, so we left off in class talking about the EPSPs and the IPSPs. Remember that excitatory postsynaptic potentials are going to be a small local potential that makes a cell more excitable, and an inhibitory postsynaptic potential is a small local potential that makes a cell less excitable. But these small potentials on their own can't cause an action potential unless you have many of them working together and then they add up to creating a large enough excitation to cause an action potential. So in the image on the right over here, you can see that there are many small EPSPs, excitatory postsynaptic potentials, right? 1, 2, 3, 4, 5, 6. Each individual one on its own is little. It's not enough to cause an action potential. But what's happening is the neuron is not getting enough time to completely repolarize to recover from each small EPSP. And so after 6 of them fire, then the cell has excited itself enough to get to that negative 55 threshold, and then it can cause the action potential here. So that means that in order for these small EPSPs to cause an action potential, they have to come really closely together so that they can add up, right? In order to add up, they have to not let the cell relax. There's 2 ways to cause summation. It can be temporal, which is the image here on the top, or it could be spatial, which is the image here on the bottom. So temporal, we're seeing that the one neuron here is firing, but it's firing very quickly. And it's firing quickly enough that the EPSPs, the excitatory postsynaptic potentials, are causing these local potentials quickly enough that it's going to cause this summing effect and eventually hit the threshold. Another way to do this is called spatial summation. That's this down here on the bottom left. So in this one, instead of just one presynaptic neuron firing, we have 3 presynaptic neurons firing. They're not firing as quickly, they're firing less frequently, but because there's so many of them firing, this postsynaptic cell is receiving as many signals as it did in the temporal, and it's not giving the cell enough time to recover between these EPSPs, and it will eventually hit the threshold. So an EPSP that is excitatory is going to facilitate a neuron. So facilitation is when it actually helps another neuron increase its effect. So in this image, here's my facilitator, and then here's my presynaptic neuron. In this, the presynaptic neuron is firing, but it's having a small effect. In this one, when I turn on the facilitator, it's going to create an EPSP that is going to increase the effect of this neuron. The opposite would be an inhibitor. So an inhibitor is going to work by turning off a presynaptic neuron. So my inhibitor is this neuron over here on the left. And so when the inhibitor is off, this presynaptic neuron is firing. However, when we turn on the inhibitor, it releases an inhibitory presynaptic potential, and that turns off this presynaptic neuron, and now there's no more nerve impulse happening here. So the inhibition suppresses a different nerve impulse. Neural coding is one of the ways that our nervous system takes the stimulus, the information that comes in, and turns it into not just an action potential, but a meaningful action potential. So that we know what this stimulus means when it gets to the spinal cord or the brain. Think about what happens when you close your eyes and you touch your eyelid. Right? If you press on your eyelid while your eyes are closed, you're probably going to see some flashing lights. Well, you're not actually seeing light, right? Because your eyes are closed. But the neurons coming from your eye are only really set up to see light stimulus, right? That's what your neurons in your eye are supposed to see. And so that line code coming from my eye to my brain, when it gets stimulated, it thinks I'm seeing light. Even though your eyes are closed, if you press on your eyes gently, don't hurt yourself. Um, while your eyes are closed, you'll probably see some flashing light patterns. And that's just because the neurons coming to your brain from your eyes are expecting to see light. So that's one way we code our neurons, is if there's a stimulus that that neuron is supposed to see, that's what it's going to see. Um, Another one is with frequency. So here is, on the graph on the left, you can see the action potentials that fire. And so the left side here, you have a different weight. So we're increasing the pressure of the weight. If you think about the difference between touching your hand lightly and then dropping something really heavy on your hand, there's a huge difference in the way we react to that, right? The way that that stimulus gets coded to our brain. One of them is like, oh, I feel a light touch, and the other one is very painful. It's not that the bigger stimulus causes stronger action potentials, because action potentials, like we've said, are all or nothing. They either happen or they don't. There's no gradation to them. But what's happening is a light touch is causing less frequent action potentials. And so not as much stimulus goes to the brain. As you increase the pressure of a touch, you're not making the action potential stronger, but what you're doing is you're making the action potentials more frequent. And then eventually, with a very heavy touch, you have a lot of action potentials. And up until this point, we've really only looked at neurons with one presynaptic neuron or one or two postsynaptic neurons. But our neurons are really set up in pathways. So we can have diverging pathways where one neuron ends up sending information to 6, or converging pathways, which is the opposite. So here we have 6 neurons sending information to a single output neuron. A reverberating pathway is where this pathway is going to be able to bring this information back to the beginning. And then a parallel after discharge. So it starts with one neuron and it ends with one neuron, but the impulse goes down several different pathways to get to that output signal. So our brain and our nerves are obviously involved in memory. But memory doesn't have like a specific place it's stored. Memory is a physical pathway through the brain. Think about muscle memory. Muscle memory is when you've done an action so many times that you don't think about it anymore. So what's happening is the physical pathway of nerve stimulus through the brain has become so habituated that you've done it so many times that now your brain just remembers that pathway. It's easier to go down neural pathways that we've set up, that we've been doing over and over and over again, and this is how we create things like habits. So there's 3 kind of levels to memory, and they're based on how long you remember. An immediate memory is just the ability to hold something in your mind for very few seconds. This is really just being able to remember what the beginning of a sentence said by the time you reach the end of a sentence. Otherwise, if you could only remember one word at a time, we wouldn't be able to read, it wouldn't make any sense. So in order to be able to read a sentence or a paragraph, you need to be able to remember what it just said. But once you move on to the next paragraph, you likely forgot what the previous sentence said. You might remember the gist of it, but it would be hard to remember the exact words. Short-term memory is very quickly forgotten if you don't continue to recite it. So if you ever tried to remember a phone number and you say the number over and over and over again, and then when you start dialing, you forget it because you stop saying it over and over again. So short-term memory can be anything as short as just remembering a phone number to dial it, to lasting up to minutes to hours. And then long-term memory are memories that are stored, that we can remember for long times. And so these can be years or all the way up to a lifetime. And sometimes they're explicit. So you want to think about recalling a memory. If you want to remember, let's say, your wedding day, that's an explicit memory. You remember what day you got married, you remember what you did that day, and you intentionally go back into your brain to remember those things. Right? It's maybe not something you think about every day, but if you wanted to, you could go back and think about it. An implicit memory is something that you don't necessarily go and look for. This might be something where you walk into a room and you smell it, and it reminds me of home, right? Or it reminds me of, oh, that one time my mom made this dish and I was like 10. And so that memory kind of just comes out at you. So you could have long-term memories that maybe you wouldn't have been able to remember that smell if you had tried to, but when you smelled it again, you remembered really well. And smell is one of the senses that's most linked to memory. And we think it's because it's got a very close link to the limbic and emotional sensory system. All right, so a couple of diseases of the central nervous system: Alzheimer's disease and Parkinson's disease. So both of these diseases are going to result in loss of brain tissue, loss of brain and neuron function. Let's talk about Alzheimer's. So Alzheimer's gets its name from the doctor who figured out what it was, Dr. Alzheimer. And the first symptoms of Alzheimer's disease is memory loss, disorientation, especially in places that the person used to be familiar with, repeating questions over and over again because they forgot they already asked them. About 11% of the United States over 65 has Alzheimer's disease. And recent studies have shown that it's caused by a buildup of something called beta amyloid protein plaques. And we're starting to realize that these plaques are being built up because of oxidative damage. So oxidative damage can be caused by things like free radicals in the circulatory system. And so when these free radicals come into contact with our tissues, they cause damage. They steal electrons, and that causes oxidative damage. This is a very similar mechanism to what causes atherosclerosis and coronary artery disease. And so what happens is these plaques build up in the circulatory system around the brain. It's going to cut off blood flow, and that starts to allow tissue death in the brain. So in the picture up on the top right, you can see that the sulci, the grooves in this brain, are extremely wide, and then the gyri, the actual brain tissue, is really, really small. And there's all of these gaps in the brain where there's no more brain tissue, the healthy brain tissue is gone, and so the memory is really affected because those neural pathways have been interrupted. And in the picture at the bottom right here, you can see this big blue molecule here is one of those beta amyloid plaques that's building up and blocking the flow of nutrients. So Alzheimer's is mostly a memory loss issue, at least in the beginning. And then Parkinson's is a progressive loss of neurons that eventually results in a progressive loss of motor function. So Parkinson's patients tend to be seen in having tremors. They can kind of start as the shakes, and then they can become very violent tremors, to the point where a Parkinson's patient who's fully progressed is not even able to button up a t-shirt because their hands are shaking. And the muscles, when they aren't stimulated correctly, can actually atrophy. And this lack of coordination between the neurons and the muscles is caused by the inability to recognize dopamine. So it's the dopamine can't be released by the neurons. And this happens in this place in the brain on the bottom, the ventral portion of, inferior portion of the brain, called the reticular foramen. We use a drug therapy recently called L-Dopa that helps with, it's a dopamine drug There's no cure for Parkinson's, but taking these drug therapies can help slow down the progression of neural damage and muscular atrophy to help with symptoms. There is a surgery procedure called the pallotomy, which goes in and actually removes portions of the brain that are damaged in an attempt to quell really severe tremors where the brain's overstimulating muscles. But this was only really done in severe cases, and then when we came out with the L-DOPA medicine, we kind of abandoned that for the medication. But in recent generations, we've been seeing an increase in the surgical procedures again because we've kind of figured out the limitations of the medicines. But our surgical skills using robots and technology and surgery has vastly increased. So the risks of this surgery aren't what they used to be in the 1950s. Now it's a much more a much more streamlined procedure. And so people with severe tremors might actually have surgery to help kind of reduce some of the tremoring.